Let's talk a little bit about oxygenation. Oxygenation is one of the critical life functions. We said oxygenation could be assessed by looking at PaO2 and hemoglobin. Those would be two important assessments of oxygenation. But before we get to that, let's talk about, first of all, we should think about lung diffusion. And lung diffusion is something that has to occur for the P-little-AO2 to be normal, and that's really what P-little-AO2 is going to tell me. It's going to tell me whether or not the lungs are diffusing oxygen properly. So if you have a normal PaO2, P-little-AO2 on room air, then it's really saying that the lungs are doing their job and that oxygen is diffusing, properly. So that's what it tells me. And like I had said before, P-little-AO2 tells me, answers the question, has oxygen moved from the lungs into the blood? And if it's normal on room air, then it has. So you see oxygen moving from the alveoli into the bloodstream here, and that's the process of diffusion, and we've talked a little bit about diffusion, but right now we're going to talk about, once it gets to the blood, does it have a means by which to be transported? And that's really what we want to talk about today. And so our topic today is oxygen transport. And there's basically two ways that oxygen is transported in the lung: in the blood's plasma, which is reflected by P-little-AO2. P-little-AO2 is oxygen dissolved in the plasma. We can measure it, we can estimate how much is there. And what I would say overall is that plasma is a poor carrier of oxygen. So P-little-AO2 tells me about diffusion and if the oxygen has gotten to the bloodstream, but it's not very reliable and dependable in terms of trying to get the oxygen transported from that point. So we want to look at it and know that there is oxygen carried in the plasma, but not very much oxygen. Actually, if we did the math and we said that the P-little-AO2 is 100, then that's only going to account for about 0.3 milliliters of oxygen being carried if you do this part of the formula, and we'll talk about the overall formula here shortly. Hemoglobin's where it's at, baby. That's what we need to carry oxygen. We need hemoglobin and we need red blood cells. Those are the primary carriers of oxygen. To put it into perspective, hemoglobin carries 98.5% of all oxygen carried, and plasma only accounts for about 1.5% of oxygen carried. So, like I had said before, plasma is a poor carrier of oxygen, and hemoglobin is the primary carrier of oxygen. So the blood gas doesn't tell us hemoglobin, so we should always be cognizant of knowing the hemoglobin and understanding that it's really important for us to know where we stand in terms of a patient's hemoglobin. So let's talk a little bit about hemoglobin itself. This says that in the normal adult, hemoglobin, there's 4 heme groups, and heme is really iron, and this is how, if someone was iron deficient, then they may be lacking proper amounts of hemoglobin, maybe anemic. And then there's 4 amino acid chains, 2 alpha, 2 beta. Mainly what I want you to know in this case is that, see the hemoglobin as basically seats that oxygen can ride on, and oxygen needs to be able to bind to the hemoglobin, and so there has to be enough hemoglobin for oxygen to bind to, but there also has to be adequate space, or there has to be availability of seats on the hemoglobin, if you would, for oxygen to ride on. Now, some of the things that might compete with oxygen for those hemoglobin molecule are things like carbon monoxide, and there are other things, but primarily if carbon monoxide is occupying the hemoglobin, then oxygen won't be able to get on the hemoglobin and be transported. So it's important to think about that. So really what I'm saying is there are two primary reasons for a patient to have anemic hypoxia. And one is that there's not enough carriers. So the person they have decreased red blood cells, hemoglobin, many times because they're bleeding or losing red cells or hemoglobin by way of hemorrhage. And then secondly is there's enough hemoglobin and red cells, but those are occupied by something else, like carbon monoxide. So carbon monoxide poisoning is a good example of anemic hypoxia. It's sometimes not thought of as anemic hypoxia, but certainly it is. So decreased red cells of hemoglobin being one cause of anemic hypoxia, and then carbon monoxide poisoning being another example. All right, so if we looked at the overall picture, we said hemoglobin is the best carrier of oxygen by far. It's what, where we need to go. And so what we're able to do with the CaO2, CaO2 is arterial oxygen content. Arterial oxygen content is the total amount of oxygen carried in arterial blood. So we were able to look at the total amount of oxygen carried by combining the hemoglobin oxygen and the plasma oxygen. If I wanted to calculate the hemoglobin oxygen, it's saying that I should take hemoglobin times saturation times 1.34. Add that to the plasma oxygen, and then I have a representation of all the oxygen carried, and this is a good way of doing that. Now, hemoglobin, but in order to do the arterial oxygen content formula, really you could just do the top line, and that would get you close enough to the answer to know what it is. Keep in mind, if these components of the formula are normal, it's going to produce an answer for arterial oxygen content that is normal. So what is the normal arterial oxygen content? We'll talk about what that is. It's the best assessment of oxygenation because it's combining both hemoglobin and saturation and PaO2 and putting all those things together into one measurement. So it is the best assessment of oxygenation. It's measured in volume percent or milliliter of oxygen per 100 milliliters of blood. All right, so if we took an example here and we said we measured all the components of arterial oxygen content and we got an answer that said 10 vol percent, low arterial oxygen content is saying the patient is anemic because hemoglobin is the primary component of arterial oxygen content and is the primary component of oxygen transport. So a decrease in arterial oxygen content is saying that the patient is anemic, and that certainly suggests anemic hypoxia. All right, bound to hemoglobin, we'd like to see oxygen bound to hemoglobin, and that would produce oxyhemoglobin, and that's obviously important. And if it's reduced hemoglobin or deoxyhemoglobin, then it doesn't have oxygen on it. And then you should also be familiar with the terms carboxyhemoglobin, which is carbon monoxide, and methemoglobin, which you should look at in the book. It's important to know the normal amounts of hemoglobin because obviously we need to assess normal to know if there's abnormal amounts of hemoglobin, there's going to be low oxygen carrying capacity. Oxygen bound to hemoglobin is obviously clinically important. If we have plenty of saturation, the arterial oxygen content is going to be normal. This is talking about how if there was 100% saturation of oxygen on the hemoglobin, then your CaO2 is going to be around 20 volume percent. If we factored in the saturation of 97, which is normally what we would do, this would say that, you know, we're still around 19.5, which is a good measurement of arterial oxygen content. Now, the normal value is going to be somewhere between 18 and 20 vol percent, so it's important to note that. Hemoglobin is only about 95 to 98% saturated, so the normal arterial saturation, SaO2, is somewhere between 95 and 98%. It's not perfect, it's not 100%. The reason being is because of shunting, and the Thebesian veins are examples of anatomic shunt, which you should look at anatomic shunt in your chapter. And this is where venous blood drains directly into the left side of the heart and mixes with oxygenated blood, so that there's a bit lower saturation. Total oxygen content is talking about taking, like I said before, plasma oxygen and hemoglobin oxygen and combining those. If you looked at a patient who's having respiratory distress and the patient looks bad, but blood gases may not tell us that the patient, you know, their condition, because it has its limitations. They have a history of anemia, so if we measure their PO2, it's normal, but we see that their hemoglobin is only 6 gram percent. So that would be half of what a female hemoglobin needed to be. It's a critical number. When we do the math, the vol percent is very, very low, and, you know, it's saying that the patient needs, from us, what the patient is going to need is 100% oxygen to saturate what hemoglobin that they have, and then eventually a transfusion. Just a look at CaO2 is arterial oxygen content, CVO2 is venous oxygen content. It's done the same way in terms of a formula. We're just using venous blood gas values. Use SVO2, and this should say PVO2 for venous oxygen content. The normal for it is about 14 to 15 volume percent. Then we can take those two numbers and subtract them and get arterial venous oxygen difference, which is basically the amount of oxygen that gets off of the tissues. Or we might call that tissue oxygen consumption. This is an illustration of it in arterial, in arteries of the systemic circulation. They're carrying oxygenated blood to the tissues, giving up the oxygen to the tissues at the capillaries, and then returning in veins. And if we would put CaO2 on this side and CVO2 on this side and compare those, the differences, how much got off at the tissues. And that's what is basically being illustrated here. The normal for CaVO2 is around 4 to 5 vol percent. A little bit of an illustration how to get there, and to take a look at that in the chapter. We'll let that soak in, and I appreciate your attention. We'll talk more about oxygenation, and our next topic will be the oxyhemoglobin dissociation curve, and I look forward to seeing you. Thanks.